All right, so we're here in the Solo Tu studio with Dr. Lauro Amezcua-Patiño, the man, the myth, the legend, the legendary. This is the most legit thing I've done with my podcast so far. So I just want to let you know that I'm super humbled that you're letting me use your studio and everything.
Absolutely. Whenever you want to use the studio, feel free to.
This is awesome. Yeah. I feel like I'm a small fish in a big pond right now, man. But we're here. We're here. So let's get started. Would you mind just kind of introducing yourself for the audience and kind of telling us what your scope of practice is and your expertise and everything? We'll kind of move on from there.
Absolutely. And I do have to say that I've known you since you were born.
Oh, yeah.
Literally, I do. Okay, so because I know your parents quite well. So it's actually a pleasure for me to have you here.
No, it's
because I think that having this kind of dual generation thing, talking a little bit about everything, in particular about mental illness and mental health and those kinds of things. But I am originally from Mexico, just like your dad, and we grew up in similar areas of Mexico, and I went to medical school in Mexico, so I'm a physician by training. I am a psychiatrist by specialty, so after medical school, I went to a specialty training in psychiatry, and I do a lot of different things, and I have done a lot of things because I've been doing this for, 32 years now. So there are very few things I haven't done in psychiatry, in everything from forensics to hospital to office to children to adolescents. My passion really is working with adolescents. I really enjoy spending time with kids and adolescents. I am a medical director for a psychiatric hospital, so I oversee the care of a lot of people in psychiatric hospitals. In my business, I also tend to see adults in my office. I have a fairly large practice, so I have probably other 9 to 10 people working under me in terms of overseeing psychiatric care for both kids and adults.
And I've been a patient of you for a long time. I don't know if we're allowed to say. Are we allowed to say that?
You can say whatever you want.
So
as long as you're saying it, you're fine.
Yeah, I've been allowed. I've been a patient for you for or a patient of yours for a long time, and it's just helped me so much. You've given me so much, knowledge and information. Helped me so much to, get over some of my, trials and tribulations as I was growing up and everything like that. Do you want to shout out your practice or
not necessarily? Okay. I have a pretty busy practice.
Okay.
We have probably more than what we can handle, and that's actually the reality of psychiatry in the United States today. Mm-hmm. There's not enough of us. There's not enough psychologists. There's not enough therapists. So there's always the need for more people.
Why do you think that is? Like, what's stopping people from wanting to practice that?
Well, behavior in particular is a difficult issue. And there's some stigma associated with that. Even among professionals, if you are dealing with people that have mental illness, maybe you went into that field because you have your own issues type of situation. So we tend to not get a lot of people wanting to get into this business, when in reality the understanding of behavior is something that is fascinating and has been a topic of study for centuries. Okay, people have always been fascinated by the idea of why do people behave the way they behave, right?
Absolutely.
So we try to grow into that, but there's a lot of people that are afraid of the stigma. Even among physicians, my colleagues in medicine, they have a difficult time relating to people that work in these fields.
Well, I think that, and education, especially in Arizona, is in a similar situation, right? We've got like something over 3,000 teacher vacancies in Arizona, where you have like students who are student teachers at Arizona State or U of A or wherever who are filling in for classrooms, or you have long-term substitutes who end up being the teacher the whole entire year. And I think that as far as education is concerned, that Hollywood and people's own perceptions of school, and obviously there's a pay component to becoming a teacher, detracts people from wanting to become teachers. Do you feel that kind of like Hollywood's perception of the, doctor who's playing tic-tac-toe in the chair and you're laying down, and how do you feel about that? Do you think that plays a role, or is that just kind of...
Oh, absolutely. Yeah. And you see, I was fortunate to train during the transitional stage of psychiatry. Psychiatry for, I don't know, 60, 70 years, even longer, was primarily in control by psychodynamics, meaning Freudian background, issues that had to do with psychology and the ego and the superego and the id, and eventually we learned that those types of theories about behavior are important in understanding people, but they're not very useful in helping people. I mean, we can make an argument that understanding leads to helping, but it doesn't help in 100%. So I was in a transition in a time when biological psychiatry became a big thing. So I transitioned from psychodynamics into cognitive behavioral, biological, social type of situations. So the most prevalent theory of behavior is more of a biopsychosocial one, where you can understand people from a biological component, from a psychological component, from a social component. Each one of those has significant impact on how people behave. So part of our job is not just to analyze somebody's behavior, is to understand the behavior. And understand the behavior in the context of that particular person, because it's very difficult to generalize behavior and say always or never. It doesn't work like that, because each individual is a very unique movie, if you may, right? Mm-hmm. So when I think about behavior individually, I want to listen to the movie of that person, so I can understand how it got from point A to point B, right? And there are a lot of issues there.
And that makes the most sense to me. Like when I'm thinking of, like if I'm looking at a student in my classroom or something like that, and I notice a behavior that's abnormal, I'm wondering what sort of impacts are happening at home, what sort of impacts are happening at school. Like what is the social dynamic here in my classroom that I have control over, but also is the student on an individual education plan? Does the student have ADHD or oppositional defiance disorder, or are they suffering with depression? Like what is it that is holistically sort of impacting or causing this abnormal behavior, right? I think that's what makes sense, where a lot of people might say, oh, that kid's just, drinks a Mountain Dew every morning before school, or, oh, that kid's just super hyper. There's something, that kid's just weird. So like, I know like my older brother has Asperger's, mm-hmm. and my mom, she became very informed, and she went to lots of different conventions, and she read books, and she got more into the biological aspect of it.
Yes.
So she was able to understand it on that level. Whereas a lot of people say, oh, this kid's just weird. I noticed that in school a lot, where like the kids who are obviously, say, autistic, or obviously something more severe, like Down syndrome, kids are willing to say, oh, that kid is special needs. And the bullying and things like that is less. But when a kid is just weird, if you don't understand the biological aspect of, oh, well, this kid maybe mutters under his breath, and that's kind of evidence of perhaps there's an autism spectrum disorder there, or something like that.
You see, over the last 30-some years that I've been doing this, I've seen a lot of people with autism, both kids and adults. I have diagnosed adults with autism when they were never diagnosed previously.
It's got to be because of that stigma, right, that existed beforehand. I mean, I know I had a special ed professor in college who said, when she first started her career, she was, I think, in her 60s when she was my professor. So when she first started her career, she said there weren't that many special ed kids because a lot of people just kept them at home. A lot of people, they didn't include them in society quite as much as we include them today because of what we know.
Well, the psychological dynamics of understanding people who are different are kind of self-defined. One of the interesting things in this business when we talk about behavior is that we've never defined what's normal, right? For some reason, we're very good at defining what is not normal.
Yeah.
But you can go to any text and try to figure it out in a text, the definition of normalcy when it comes to behavior. There's no such a thing. Why? Because it's a wide range of behaviors. And you have a lot of people that are at the ages of normalcy because of how they relate or how they behave. And we have to look at two different things. One is how much and how often, right? So if it's happening a lot and it's happening very often and it's causing you dysfunction, meaning you can't function psychologically, socially, biologically, then we determine that that is outside of the norm, right? And then we put labels on it. Autism in particular is a well-defined neurodevelopmental disorder. There's specific issues, but you're absolutely right. You get into the issue of, okay, the brain is different and they relate differently, okay? Does that make them abnormal? No, it doesn't make them abnormal. It makes them different in terms of how they relate. And part of the problem, and you're a school teacher, and I work with adolescents in the psychiatric unit. That's my direct care issue. And I have a team of people that work with me on that, is that adolescents in particular are very cruel.
Yeah, right? Yeah, absolutely. They can be
so where does that come from? Where's the cruelty come? And kids in general are. What happens with adolescents is adolescents tend to mature intellectually faster than emotionally. So adolescents are very logical, right? They're very black and white.
Yeah.
But they don't handle uncertainty very well. So when you put them in situations that creates uncertain emotions, they react in very predictable ways, whether it's anger, frustration, depression, and so on. So you have to be able to listen to that and not to punish the excessive intellectualization because of their anger discontrol. Because every adolescent is going to have some of that, right? And I think in part that's because adolescence is a process of separation. It's a process in which you're learning to separate from your authority figures and become your own person, right?
Yeah.
So in that process, you try to find logic. There are other dynamics that have changed over the last 20, 25 years in terms of parenting that have actually changed things in different ways.
Yeah, absolutely.
In terms of helicopter parenting, not allowing our kids to take risks. So kids are basically being raised in boxes, right? They go from one box to another box to another box. So the sense of community, okay, it gets lost. So kids don't learn from experience on the streets. They learn from experiences in the boxes. And that creates other set of complications.
I listened to your podcast, or one of the first ones, where you talked about how there has not been a defined definition of normal, right?
Yes.
Are we sure that when you say there hasn't been a definition of normal, like there's not a medical definition, an accepted definition? Because I feel like if you go into my classroom and you ask kids to blindly choose like which kids are normal and which kids are not, they might choose the kid who is, follows the rules, communicates pretty clearly, likes things that are pretty mainstream, conforms to the rules pretty well, comes from maybe a dual parent household. So there's a kind of a societal factor in there, right? Like a cultural factor. So there's like all these boxes that are checked. And if you fall outside of that, then maybe you're less normal than someone else. Like, for example, like I grew up in a predominantly white neighborhood growing up. But my name's Juan Pablo De Leon, and kids couldn't like pronounce my name when I was younger and such. And so I wasn't quite normal culturally, right? And my English is my second language, but obviously like now it's pretty much my first language because I've spent 99% of my time in the United States speaking in English. But when I was little, I remember like having to, code switch all the time between Spanish and English, and I would forget really simple words in both languages. And that would make me come off as somebody who was kind of dumb and abnormal, right? So, normal is just such a subjective term, right? You couldn't possibly define it. That'd be pretty daunting, wouldn't it?
Well, it's not just daunting. Is that what you describe is not necessarily an assessment of normalcy, it's a judgment of normalcy, right? Mm-hmm. So one of the rules in my business is to not judge. Okay, so you can't make the assessment based on my own cultural judgment, because that requires that you separate, right? And those are actually this significant basis for discrimination, right?
Yeah.
I won't accept you because you're different, and because you're different, you're not normal. So that is trying to utilize your own concept of yourself and try to mirror it into somebody else for them to be you, right? So if you're not like me, you're not normal.
Yeah.
And that's a judgment, right? So we see a lot of that now. I did when I came to the United States. I've been a U.S. citizen since I was born because my mom is American, but I didn't come to the United States formally until the early mid '80s, right? I always thought of the United States as a very open-minded society until I moved here, right?
Yeah.
Until I realized how judgmental American society is, and how much of acceptance is based on judgment, not on understanding. So there seems to be an inability to listen. I think that in the United States we talk too much, and we listen very little. And if you want to learn about somebody else, you have to listen. You can't just put those barriers of judgment in terms of your own way of looking at life. And that has gotten worse. And I think that that's been one of the complications of social media, right? That really allows you to make judgment on very limited data, if you may.
Yeah, I mean, this is something I focus a lot of my community building at the beginning of the school year around building our classroom culture. And especially like as an English teacher, there's a lot of sharing, there's a lot of presenting, there's a really big aspect of communication in an English course. And so it's really, really important for my students to feel comfortable.
Yes.
So at the beginning of the year, there's a few things that I say to kind of help detract from this judgment that might happen in other courses. Maybe more fact-based courses like a science course or something like that, right? Like you can obviously be very wrong right off the bat in a science course, but if you can defend your point with sound logic in an English course, you might have seemed wrong in the beginning, and prove yourself right later on. But one of the things I say is you don't know what you don't know, and that's okay.
Correct.
So if you haven't experienced something and you don't know about it, then you really shouldn't be judged for it because you're a child. You're 14, 15, 16 years old in, the case of the students that I teach. And it's not your fault that you've never been to Mount Rushmore or you've never been to Washington, D.C., and you don't know what these things are because maybe your parents just didn't teach you about it, or maybe you haven't caught that in school yet. Another thing I always tell my students is that you don't know everything about this person's life. You don't know if they woke up today and they got breakfast, or if all their clothes wasn't washed, or if they had to get their siblings to school. A big phrase that we always use is like hurt people, right? So like if somebody's upset or mad or hurtful toward you, it's very likely like they're angry about something else. They're not actually angry at you because like, what have you done to them? Really, probably nothing that drastic. And then this idea of like accepting everybody, because just because they're different from you doesn't mean that you don't have something in common. Just the fact that we're all humans, kind of like we have more in common than we have differences based on our own humanities. I would say, I don't know what you think about that.
That's an interesting concept, because for a lot of people it's very difficult, the idea of blinded acceptance, right?
Yeah.
And I'm not opposed to it. I think that it's perfectly fine. I tell my patients and my students, because I'm a teacher too, I train health professionals, that you don't have to like or accept the people you love, right? So why do I say that? You don't learn that really well until you have children, right? They very often you don't like your kids. You love them though.
Yeah. Well, that's how I am with my students. Like a lot of teachers will kind of lie and they'll say like, "Oh, I love all my students," and I'm like, "You're lying."
No, you can love them. You just don't have to like them.
Well, I guess they use the words interchangeably. Exactly. You know what I'm saying? So like for me, I'll tell my students straight up, like, I might not like you. Like we might have issues this school year because we're not compatible as humans.
So I was telling you, you see what one of the things that happens, and I see this a lot with kids that have family problems, right?
Yeah.
And they have ways of looking at life different than their parents, right? And they come into the hospital because they're suicidal. And they said, I want to die because my parents don't accept me. Right? And I use a lot of something called paradoxical intention, which is you just do the opposite of what the kid expects you to do. So I would ask them, why should they accept you? Right?
Yeah.
And the kids have a very difficult time answering that. Right? And sometimes the issue is usually somewhere in the moral, religious conflict between the child and the parents, right? And
like they have different views on...
Well, they have different views and they have different approaches to things, right?
How much of that has to do with just generations? Because I find that with my parents, my siblings and I find that with our parents.
Absolutely. Most adolescents will travel that time, okay. And this to some degree expected that you're going to have different views and you're going to have different ways of coping with that. But when that translates into you thinking my life is not worth anything because my parents don't accept me, then I have to say, wait a minute, do they love you? Do they care about you?
A lot of kids will say no, right?
Exactly.
A lot of kids will say, no, they don't love me. They just want to ruin my life. That's such a perception issue.
Exactly. So that's a perception of the kid, right? So you want to explore those particular issues. Now, I have to tell you, I've seen parents that don't love their kids. That's rare, though.
Yeah. Well, I mean, does it manifest itself in like negligence?
Yeah, but you see, what happens is that you have to define how to measure parents caring, right?
Yeah.
You see, if you think that your parents don't love you and don't care about you because they don't let you go and have a beer and you're 15 years old and they don't let you stay out until midnight, well, they're actually caring by not allowing you to. But your perception is they don't care about me because some other parents allow their kids to do that. So you can get into trying to define. So it's very important to try to understand the dynamics of that particular family, right? Because one of the things that kids have a lot of difficulty with is that they get confused between discipline and not loving, right? And again, I like to tell my students this all the time. You raise your kids until they're 12. Between 12 and 25, you contain them. Right? And kids don't like to be contained.
That's true.
So in the context of containment, kids are going to rebel somewhat. So we're back to the same situation, which is most things that have to do with abnormal behavior have to do with how much and how often and how it affects the dynamics personally and interpersonally, right? So we always, I mean, if you have a little bit of a problem getting along with your parents, you probably won't go to my office. Or you probably won't try to kill yourself.
But if it's constant,
but it's consistent
and unrelenting,
and intense, unrelenting, and it's causing you dysfunction. Your grades are going down. You're starting to experiment with drugs. You run away from home. I mean, we're talking about significant issues. Most issues that you're going to deal with school, for example, have to do really with things that are on the fence. They are somewhat dysfunctional, they're somewhat different, but they still go to class, they still get up in the morning. And those are something that can easily go under the radar and not be caught. And that's where school becomes important, that you have to make more of an effort to identify.
Yeah, I know. I mean, for me, this is something that, they teach us a lot in schools, and I take it really seriously because it makes me more effective. Like what you're talking about is up to a certain point, your relationship with your child changes, right? So how do you continue to build that relationship in those years where you have to contain them, as you said? I think that a lot of people, or something that I notice in parents and students, is that both parties stop trying to build a relationship. They're continuing this relationship on a foundation that no longer works, because you're not a little kid anymore. You don't want to, just driving around in the car with your mom while she does errands isn't like satisfying anymore. There's other things you want to do and such. And I've had students come to me and say, like, my parents don't understand me. And I was like, well, do you understand them? And they always get stumped with that question too. And I'm like, what do you do to help them understand you? Because no one wants to understand someone who's hostile and angry, because there's a problem to be solved there.
But I think there's a point there when you said somebody who's angry or hostile. you have part of our job in my business is to understand what is the message that is being delivered by being angry.
In this case, it would be like, you don't understand me. You don't know about my.
Usually, there's more to it
Okay.
than that. I mean, if you get to the point that they're coming to a place like me, or going to a psychiatric hospital, or having to see a therapist, something else is happening. Okay, that the relationship is getting imbalanced, if you may. And when you were mentioning a minute ago, okay, you asked the kid, well, do you understand your parents? I think it's also important to listen to the answer, right? Most of the time when we're working with kids, we're trying to understand how come, not why.
Yeah.
And you're an English teacher, so there's a difference between asking how come than to asking why, because why implies judgment, right? So I keep getting back to the same process. If you want to listen to what a kid has to do, the kid has to feel that you're not judging them.
Yeah.
Kids tend to be very sensitive to that.
Language is so important. Like the way in which you pose a question is extremely important.
Exactly.
Because saying, why'd you do that, is way different than, how come you... That's something I'm definitely going to take. I appreciate that. Can we rapid fire some questions?
Sure, absolutely.
We're just going to rapid fire. We'll get through them because these are some questions that I wanted to hit, and I'm sure we'll dig deep into them. We talked a lot about, different sorts of mental illness or mental health. What do you see, what's the most you see in kids today? We talked about how family dynamics and social media contribute a little bit. What's the most common things you see today?
The most common thing, it depends. In my office, where we see the most common thing is usually anxiety disorders.
Okay.
So excessive worrying or excessive anxiety socially, or stage fright, difficulty speaking in public, those kinds of things are so common that people forget that they can be pathological, right? So it's important to understand, okay, is the worrying keeping you from sleeping? Is the worrying getting to the point that you're not being able to go and spend time with your friends? Are you becoming so self-conscious about what other people think of you that you are limiting your space and your growth? So we have to look at those as something pathological that doesn't necessarily something that requires aggressive psychiatric treatment, but it needs to be looked at, because that person is no different than somebody having a leg shorter than the other and trying to run marathons and nobody's getting them the special shoe, right? So it becomes like that. It's important. It's not that they are defective, it's that they're having some intensity in the way that they cope with life, whether it's biological or psychological, that doesn't allow them to be able to function.
So it's kind of like what we said at the beginning of the podcast. There's biological and
psychological
and social reasons that all contribute to that.
All right. You see that the biopsychosocial component is extremely important when you're going to treat something, because you have to treat those three ways. We'll get to that.
Yeah. So as far as mental health, on their, let's say we're talking about before they ever get to you, right? A lot of times, a kid commits suicide or shoots up a school and people point the finger at schools, right? That schools aren't doing everything in their power to help with the mental health of students. And I find it really easy for me, since I'm so close to my students in age. I relate to them. It wasn't that long ago that I was in their shoes, and they confide in me, and they don't feel that same level of judgment that maybe they would feel from some of their older teachers that fall into this same category as their parents. Do you feel that schools do everything in their power, or as much as they possibly can do within, their institution, to help educate or help kids who have mental health issues? Or do you think that there's something missing there?
Well, it is too easy to say school is not doing what it's supposed to do. And different schools do different things.
Yeah.
And different schools have different budgets. And there are a lot of political, social issues that impact how a school is going to respond to one thing or another. Specifically about suicide, though, schools have a responsibility to do one thing, which is to identify people at risk. Mm-hmm. It's not the job of the school to keep people from killing themselves. But it's neither the job of the family doctor or the psychiatrist, right? Neither the job of the family. It's all of our job together okay, to identify who's at risk.
It takes a village.
Exactly. So who is at risk of attempting suicide? Well, people that have depression, people that have serious anxiety, people that have substance abuse. So we're not paying attention to try to screen people for those disorders, right? I mean, you're going to hear a lot about suicide prevention, for example.
Yeah, we received an extensive amount of education about that.
Yeah, but suicide prevention is kind of a misnomer, right? Because it assumes that you can prevent suicide. You can identify people at risk, and you can provide treatment to reduce the risk. Okay, but if you look at statistics over the last 50 years and see how many suicides we have prevented, meaning that the incidence of suicide has gone down, no, it hasn't gone down. So we are getting better at identifying those at risk, so the incidence of suicide is not going up, right? But there's two groups in particular that we're terribly concerned: adolescents and the elderly. And that changes over time, right?
So there's a lot of suicide in elderly people?
Oh, yeah.
Oh, wow. I
Absolutely.
didn't know that.
In particular, in males who lose their wives.
That makes total sense.
Yes,
but it's not covered.
You don't hear a lot
about it.
Yeah. But like when I'm training family physicians, I tell them, listen, if one of your patient comes to you and is 82 years old and his wife died 2 weeks ago and they look great, worry about that patient.
Be super
They're not
worried.
supposed to look great, right?
And this might be just me defending when the finger is pointed at schools. But I feel like, the schools that I've worked in, I interned in some lower income schools. I currently work in a school that's, pretty affluent. And then my last school that I worked at was somewhere in the middle, more or less.
Yes.
They all have like a school psychiatrist or psychologist who's like available to the students at all times. Social workers. My last school, my current school, had a team of behavior specialists and interventionists who, they were always just, at the students' disposal at any time. They would pull kids out of class and we could refer kids to them. It was a really good system. Schools offer sports. Schools offer clubs. Schools offer, they have hotlines. I feel like there's so many systematic things in place that work for, and I guess I don't know what better use to I don't know what better phrase to use other than suicide prevention.
Mm-hmm.
But
that's a great word.
all of those things are there, not just to elevate a child, but also for that, right? So I'm always like, when people say, oh, the school's not doing enough to teach about social emotional health and yada yada, and I'm just like, no, we absolutely are, but this is an issue that is out of our hands, as you said, right? Like, it's not something that we, can always be on top of.
I have had patients commit suicide.
Yeah.
Right? And the first time that happens to you as a psychiatrist is pretty traumatic. And the first time that happened was, 30 years ago, right?
Wow.
So in my specialty, I have mortality like a cardiologist or like an internist or any other doctors, right? So people die. And whenever we have a suicide, we tend to do what I call a suicide an autopsy, right? We actually go back and look at a lot of different things.
So do you go back and look at like their behavior leading up to it?
Yeah, behaviors leading up to this. What were the things that happened? What are the psychological, social circumstances? Because suicide is complex, right? It's not a cause and effect type of situation. We're probably better than most on identifying people at risk, right?
We being psychiatrists,
psychologists, therapists. We're trained to do this. But sometimes you're going to miss some people, right?
Yeah.
And then you have significant social and psychological circumstances that are not lending themselves to reducing the risk, right? For example, domestic violence at home, alcoholism at home, the kid being abused and somebody not intervening. There are a lot of things that are very complex psychosocial dynamics that can lead a child to attempt suicide, right? And some of those kids are going to die. So it's very important that we really have an understanding of the process, right? Identify people at risk, like somebody who's being bullied. Yeah, that's a major issue in schools nowadays.
Absolutely,
right?
yeah.
So not everybody who gets bullied is going to get suicidal, but some people will, and we need to take that seriously. Something that I've seen different in the last 40 years is that parents have become very protective of their kids getting psychological help in school because it's kind of a stigma, right?
Yeah.
So there's this kind of imbalance, if you may. And even if you identify somebody at risk and you call the parents and you talk to them,
They want to try and handle it themselves.
or often they feel offended, right? And that's a very difficult position for the psychologist and the therapist. You can't help a child without the parent's help.
See, that's why I think it's so important for teachers to build close relationships, not just with their students, but with their students' families, which I know is tremendously difficult. But I know in some cases, I've had teachers who or colleagues who have done that, who have had issues trying to get this kid the help that they need.
Yes.
And because of the relationship that other teachers have to them, we say, okay, it's better that information come from this teacher instead of that teacher because they have a closer relationship. So the parents and the student are going to respect this other teacher's recommendation or analysis of the situation a little bit more than...
There's got to be a partnership, right?
Yeah.
And it's a partnership with families,
like you're
teachers.
a stakeholder in the health of this child.
Exactly. So what happens is that something has changed over the years in which the idea is now that kids are being raised in school, right? Kids are being educated in school. Okay, I don't think it's the responsibility of a teacher to raise any kid.
Yeah.
That's the responsibility of the parent.
It's really difficult as a teacher when you see that someone's not doing a job to assume that job. It's really hard.
You should not assume that job.
I know
it's
hard.
difficult.
It's super hard to not intertwine teaching life skills and personal awareness and social emotional awareness into my lessons. I do it constantly. It's like
I understand that, but you
have
have to be very careful of defining boundaries because you see, we deal with this all the time, right? That I have a kid who is being abused at home, right?
Yeah.
Physically, sexually, parents are not very cooperative on the help of the kid. I will call the authorities. They say, well, we couldn't find any evidence of anything. The kid has to go home, right? And I'm having to let go of a child to a home that I know is not conducive to that kid's rehabilitation.
And in this case, like the kids
don't necessarily do anything. I mean, the kid is not gonna get any environment.
But in this case, did the kid confide in you and tell you, my dad is touching me or whatever?
Oh, absolutely. I mean, that's every day. I mean,
and that's not proof enough that they told their psychiatrist
there
that's
has to be evidence.
There has to be physical.
I mean, it's not my job to investigate. It's
Yeah.
the job of the authorities. If the authorities come back to me and say,
We didn't find any evidence.
we didn't find any evidence, and the parents want the kid home, I don't have a choice.
Yeah, no. There's nothing
So
can
you
do.
deal with that situation all the time, right?
So, kind of moving forward here, I've been, taking medicine for a sleeping disorder for a long time now. And I've been told lots of different things by people like, why are you doing that? Like, you don't need to be taking that. Like, you can change your diet and your habits, and then your body won't need that. Your body doesn't need that. Neanderthals didn't take antidepressants and things like that. And a lot of people feel, there's this conspiracy behind, getting people medicated and things like that. And especially after this coronavirus situation, I know for me, I felt really self-conscious because one of my medications was on back order at this at the pharmacy where I was getting it filled. And I was like, dang, which I've always been a fan of like zombie movies and apocalyptic type movies and things like that. So I'm sitting here thinking like, man, if the zombies come and all of this disappears,
That doesn't matter.
I can't, it doesn't matter. But what if I survive? Where am I going to get my stuff? I'm going to freak out and then I'm going to turn into a zombie before I even turn into a zombie. So, there's a lot of people who say, which I'm obviously joking about that,
Yes,
right?
absolutely.
That, you don't actually need things like antidepressants to treat, these, disorders and things like that you can kind of heal yourself with more natural remedies and exercise and good diet. And a lot of people, especially kids my age with, the legalization of medical marijuana, and my friends who live in California where it's just straight up legal. They can go to a dispensary and just buy it. They self-medicate. And I know that's something that at the beginning of this school year, our district talked a lot about students self-medicating, not just with marijuana, but with like vaping as well. What are your thoughts about this sort of culture of anti-medicine for, psychiatric issues?
Remember that we talked about biopsychosocial issues, right? And in the biological component, we have genetics, right? We have symptoms. And you can apply the biopsychosocial model to any illness, whether it's psychiatric or not. So you have biology that has to do with how you're made and what symptoms you have, what illness you're vulnerable to. You have your psychology that has to do with how do you feel about yourself and how you relate to your own emotions. And then you have sociology, which is your social environment, your family, your friends, your school, all of that. The purpose of treatment, whether it's diabetes or whether it's depression, right, or whether it's hypertension, is to find balance. Meaning, remember that I said before, intensity, frequency, and dysfunction, right? So if your blood sugar is 120, right, 140, and you're early diabetic, you may very well just control it with a diet, right? But all of a sudden, somebody close to you dies and your blood sugar goes up to 300, and the stress is causing you to have a diabetic crisis, and you said, no, I'm going to manage it with diet alone. And I would say fine, as long as you understand the risks, right? And the risk is that you'll die. Okay. So do you want to get some insulin or not? Part of the problem is this idea that some people have that physicians dictate treatment. We do not dictate treatment. We dictate options. Our job as physicians is to identify disorders biopsychosocially and provide you with options that you can exercise. The problem, why is pharmacology so prevalent, is that most people are not willing to do the psychological and social treatment, right? So if you come to me and you're in a bad relationship, right, and you're severely depressed, and I give you an antidepressant, right, and you respond, your symptoms get better, right, but you don't do anything about your relationship, and you're drinking and you're doing drugs, well, don't come back to me and tell me the medication is not working, right?
Because you didn't do your job in your real
Exactly.
world.
But the same thing happens with diabetes. If I give you insulin and you come back and say, well, doctor, my blood sugar is still 320, I said, well, stop eating, right? I mean, there's certain things that you have to do that medications don't do for you. So part of the problem is that there's been somewhat of a push to believe, especially in this country, that medications fix things, right? Medications don't fix anything. At the best, medications reduce intensity of symptoms. So I like to tell my patients, listen, medication will do 1/3 of the job. The other 2/3 is up to you.
See, and that's what my experience, being treated with you has been. So just so that my listeners know, when I was in middle school and early on in high school, I started getting, really intense sleep anxiety, night terrors. And this is something that I had always growing up, but, it's something that I should have, probably grown out of by then. But it, like you said, increased in intensity. And I was a healthy kid. I didn't, at this point, when I was younger, I wasn't quite as healthy as I was at the point when, I started getting treated by you. But, I was healthy. I did sports, good family, like everything in my life was really positive. So it was mind-boggling to me and my parents as to why this was all happening. That's why I went to you and got that help. But I definitely find that for me, regardless of whether I take my medication to fall asleep at night or not, if I didn't do some sort of physical activity that day, if I've been eating nothing but junk food, if I've been watching things on TV or on YouTube that stimulate me negatively or positively, whatever it is, if I'm highly stimulated right before going to sleep, like I can't work out. Like a lot of my friends will go work out at 8 or 9 at night. And I'm like, I can't do that, man. I won't sleep. I won't fall asleep till 3 a.m.
Correct.
So you're right. Like there are things that I have to do on my end for my medication to work. My medication takes a little bit of the edge off.
You see, one of the things that we don't realize is that people don't go to the doctor because they're ill. They go to the doctor because they have symptoms and they want somebody to listen about those symptoms in the context of their life. So it's not that the patient is diabetic, it's the patient has diabetes. It's not that the patient is depressed, it's the patient suffers from depression. Part of the problem in this country is that we tend to define the humanity of that individual based on their illness. So you say, he's schizophrenic, he's autistic, he is this, he's that. No, it happens to be a human being that suffers from this, right? Because we tend to minimize the humanity of people. We forget that people are human beings that suffer, right? And people don't want to be treated. They want your help with their suffering. And their suffering is biological, psychological, and social. So there needs to be a treatment plan that includes
all of
those things, right?
And I feel like I've seen this just in my short teaching career. I've seen kids who, children who suffered from hyperactivity of some kind, ADHD or ADD or whatever it is, right? And their parents put them on medication, and this kid is like a zombie. The kid falls asleep in class constantly, can't focus on anything, doesn't do work, but now at least they're not bouncing off the walls. Is that kind of an example? Because I think that's something that a lot of parents are afraid of.
Yes.
Is I don't want to put my kid on medication because I don't want my kid to become a robot.
Well, that has a lot to do with who's prescribing. You see, one of the rules of pharmacology is treat to efficacy or tolerability, meaning either the patient gets better, and if the patient gets side effects, remove that. So the patient being a zombie may have more to do with regulating the medications to where you can find the best efficacy with the least amount of side effects. So that's something you have to work with the individual. That's fairly common with attention deficit disorder. Attention deficit disorder is a fascinating disorder. It's a purely genetic disorder. It runs in families. If you have a child with ADHD, there's probably 70% chance that one of the parents has it too. And sometimes the medications make the kids lose their personality, and the parents don't like that, the kids don't like that. But there are a lot of issues that can be dealt with without medication in attention deficit disorder. But think about being in a home where one of the parents and the child both have attention deficit disorder, right?
No, I mean,
so that's problematic
there's
too.
Some giant lapses in communication that can happen there, and understanding and patience.
So nobody's listening.
It's got to be patient, a huge patience issue, right?
Absolutely.
Yeah.
Absolutely. Yeah.
I know that, it gets difficult as a teacher because you can only reach so far.
Yeah.
Legally, like I can't tell a parent, here's what you need to do with your kid, because I can get in huge trouble for that. But I've had kids who, their parents do the opposite, right? Like their parents put them in sports, and they don't let them have kind of like this helicopter parent. And I would say that it's almost like that's their only choice. They feel like they have this kid who, if they're not constantly on task, then they get into trouble, or they do things that are not conforming to the rules of their home or their school. So, they wake up, they go to school, they go to sports, they do their chores. Their parents have them on this very regimented schedule. And as a result, I find with those kids that they do kind of, and it's like, what are you going to do? Are you going to allow this kid to have this individuality with potentially destructive results? Or are you going to regiment this child's life and not have those results? That's something that I see a lot. Like I have a parent who became like hyper obsessed with their kid always being in sports, to the point where I'm like, do you even, like, your kid feels like you don't know them because you're never with them really.
Well, let me say something, because I deal with so severely ill kids. I get a lot of parents that often come to me, especially when the kid gets hospitalized, and ask me, "What did I do wrong? I mean, what am I doing wrong that my kid decided that she wanted to kill herself, right? Or took an overdose, those kinds of things." And I have to tell you, my experience over the last 30 years is that most parents, and I would venture to say like 98% of the parents, don't wake up in the morning thinking how they're going to destroy the kids' lives.
Oh, yeah, of course
okay?
not. Yeah.
So it's extremely important that you reassure them that they're doing the best they can with what they have, right? But also you have to be willing to ask one question, because it's not about what you want them to do, it's what they're willing to do. And the question is, how do you want me to help you? Okay? Parents are going to get tremendously defensive if you judge them, if you tell them you're doing something wrong, right?
Yeah.
But you cannot ask that question until they come and ask for some help, right?
Yeah.
So it's very difficult to force parents because their intention is usually positive, right?
Absolutely.
So I mean, I have seen parents, or we could call it bad parents, right?
Yeah.
That they wake up in the morning angry, frustrated, beat up
Take
their
it
kids.
all out on their kids.
Exactly. But that's an exception, though. So we can't think of every single parent in that context. We have to be not judgmental and be willing to listen. So, especially when the kid comes to you, okay, and the kid tells you, I think that this is too much. And usually you start seeing it because the grades start going down. The kids start looking sad. It starts participating less in class. It's not relating to their friends as good as it used to. So you that's what you have to be paying attention to, okay? But also with the kid, you have to be very careful not to go and say, what's wrong with you?
Yeah.
Right?
Yeah, and I often find myself just relaying information. Like, I'm not giving my opinion. Even when a kid gets in big trouble and I write a referral, it has to be really, really objective. Here's what happened. In this case with parents, here's what your child told me. Let me know if there's anything I can do to help, or if there's any information you would like me to convey to the child, or if we can set up some sort of mediation and I'll go sit down with the counselor and you and the kids. I find that works really well because I'm not giving that unsolicited advice. That's not my place to give it anyway, really.
Exactly.
As the teacher.
But again, you're in a difficult situation. You're in a tough job.
Yeah.
I mean, there are very few jobs like yours. Okay, there are very few jobs where you have to balance so many different variables, and where the expectations from the people on the outside are so high that you're going to do things for their kids that you're not supposed to be doing, right? And that's becoming more evident nowadays, in which the fingers gets pointed if something goes wrong and say, well, you didn't do your job. And your job is actually to educate.
Yeah.
More than anything else.
At the end of the day, a teacher is supposed to give you, especially like K through 12 education, is supposed to give you the baseline literacy skills for you to, continue your learning or be a contributing member of society, right? Mostly, originally, it was to give information, right? So that we had an educated
think of it this
school
way.
system.
You're one of the trainers you're one of the coaches in a team, right?
Yeah.
And there's several coaches, and you coach a very specific skill. Everybody in the coaching team, everybody, is doing one job. It's training that kid for the rest of their life. Right?
Yeah. It's a big task.
Yes.
Yeah.
So, but when people start pointing fingers and saying, no, it's your job to train my kid for the rest of his life, right? Then he's negating the responsibility of the rest of the coaching team.
Yeah. Well, the learning is in the work, I think, too, though. Like, if you, for lack of better words, kind of stay in your lane, then the learning happens, whether it be just content-based learning or something more, metaphorical, where this lesson you learned from this work that you did or this experience you went through in school carries on to the rest of your life. That happens, in my opinion, if you're a passionate teacher, if you're invested and you work really hard to make what you're teaching relevant to your students, then
you see what I find
what
I find most challenging, I think, for teachers, and it's really not part of your training. It's very difficult to see people you care for hurting emotionally.
Yeah.
Right. So it's very difficult to define the boundaries in terms of how much can you do to facilitate the recovery of that individual.
Yeah.
And again, we're back to intensity and frequency, right? And how is that affecting you? So if you have a little headache, it doesn't bother you too much, you're not going to go to the doctor. But you have a headache that won't let you go to sleep at night, and you've had it for 3 nights, and your blood pressure is going up, you better go to the emergency room, right?
Yeah.
So you have to identify how much, how often, and how is it affecting that person.
And I will say, like, I'm really optimistic, even when I was in, when I was teaching lower income students. I'm really optimistic about the future of, our youth. Most kids are going to grow up and be totally fine. And, that's why you can drive down the road and there aren't 1,000 crashes all along the road, right? The majority of people are all good. One more question.
Go ahead.
One more. Medical marijuana for treating disability or mental health disorders.
Okay, there's enough biological evidence that medical marijuana should not be used with children and adolescents, and it has nothing to do with the morality of drugs. It has to do with the brain development.
And adults?
Once you pass 25, okay, your brain has actually kind of finished development, biologically speaking. All of your neurons are connected as good or as bad as they're going to be, right? But if you start putting substances in your brain, including marijuana, as a teenager, you're actually affecting normal brain development.
Got it.
Yeah.
Well, all right. That was a really awesome conversation.
Thank
I
you.
really appreciate it.
We should do it again?
No, absolutely.
Yeah.
I would love to. I mean, we can, like you said before, we were talking before the podcast, we could have a 45-minute conversation about each of these topics individually.
Yeah, and that maybe when we start doing some recording of my show for in English, maybe you can help me with that too.
Yeah, I would love it.
All right.
So we'll shout out the Solo Tu
podcast,
and then you have the Only You podcast in
yeah.
English. Some of my listeners are from Mexico.
Oh, really?
Yeah, it delineates it there on my app. I think it's like 2% or something like that. Maybe it's just my family or something in Mexico listening. Thank you so much again for getting on the podcast. I really appreciate it. And thanks for doing everything that you do.
Well, thank you for being here. Thanks.
Excellent.